As you would have seen from the chart, the $7 co-payment has created, or proposal for a $7 Medicare co-payment has created quite a bit of discussion, reflection, controversy, comment and opinion. And the panel this morning is focused on 7 ideas to replace the $7. We've got an extraordinarily eminent panel of commentators that you no doubt will have seen in the press and certainly in public policy circles over the past few months, talking about not just the co-payment but a whole lot of public policy issues relating to health policy and health financing. As I said yesterday, the speakers' bios are in your pack, so I'm not going to go into them in great detail, but we have Professor Stephen Duckett, Associate Professor Adam Elshaug, is that right? Excellent. We are a panel of Adams at this event. Jennifer Doggett and Professor Andrew Podger. So can you welcome the panel for me? And I'll start by inviting Professor Stephen Duckett.
Thanks very much. Do you mind if I just talk? If you can't hear me, wave your hand. And if you don't want to hear me, you can go outside and have a cup of coffee. So I'd like first to start by acknowledging the Aboriginal elders past and present, and remind us that when we make those acknowledgements in a health audience, they're really important, because Aboriginal people are still suffering discrimination, still suffering disadvantage, still suffering 10 or 15-year shorter life expectancy. So those acknowledgements should always remind us that we need to do something, not just say something. So my talk, I was asked to talk about 7 ideas to replace the $7. I wrote a little piece based on this speech in the conversation which came out this morning. And already there's a comment there which said, well, there's an 8th idea that you didn't talk about. So please forgive me that I haven't got every idea that we should, and I've left some space for poor Andrew, who's the last speaker. So my first tip is this: don't panic. And that's really important, because we have these henny pennies running around telling us the sky is going to fall in, and that we've got an unsustainable health system, and that before we know it, we're going to be spending 100 billion% of our gross domestic product on healthcare. Well, the fact of the matter is this: we spend about 9 and a bit% of the GDP on healthcare now, and in 20 years' time or so, we're going to be spending 12 and a bit% of gross domestic product on healthcare. In the United States, they spend 18% on healthcare. So there is plenty of room for us to move. The other point is this: here, I work at a think tank, which means we think, and it also means we can keep 2 ideas in our head at the same time. Wow. I know it is hard, but we try and keep 2 ideas in our head at the same time. When I go to the Victoria market, as I do on a regular basis every Saturday or so, and buy my tomatoes, I have a choice of stewing tomatoes and truss tomatoes. The stewing tomatoes are cheaper. That doesn't mean I automatically buy the stewing tomatoes, because there is cost and quality. You actually keep 2 ideas in your mind at the same time. Unfortunately, in Australia we have a place called Canberra, which means 1 idea at a time only. And people in Canberra can only have 1 idea in their brain at the same time. And they can only think about cost. They can't think about value. They can't think about quality. What if I told you that over the last 20 years or so, the death rate from what's called amenable mortality, that is mortality from conditions that the health system can do something about, has halved. So yes, we have spent more money on healthcare over the last decade or so, but we've got something for it. There's a cost and benefit trade-off. I know it is a hard concept to think about. I know that poor people in Canberra cannot cope with 2 ideas in their brain at the same time, but hopefully people in this audience can. The second thing about health, about sustainability of the health system, and the reason not to panic, is this. They say, oh look, ageing is really important. Well, ageing is important. I'm getting older. But one of the other points is, I get older 1 day at a time. I didn't wake up this morning and discover I was 20 years older. I woke up this morning and discovered I was 1 day older. So ageing is something that happens very, very slowly. And I call it a grey glacier. Change is happening, sure. The Australian population is getting older, sure. But it is not a silver tsunami. We're not going to be overwhelmed tomorrow by an outburst of aging, which means that we can prepare and change the system as change the system we need to do to account for this aging. And the other point is, of course, that aging hasn't historically accounted for a lot of the growth in health costs. The second point I want to make is this. We've got a range of policy levers that we can use to change the health system. We can provide information about comparisons. We can provide financial incentives. We can introduce new services. We can try and change the value and the culture. We can try and change legislation and rules. We can set up new organisations, and we can actually talk and use our rhetoric to change the system. Basically, the Labor government did two things. Well, three things. It talked a lot, and the best example of the talk were the Medicare locals, where the Medicare locals were going to solve all the problems of the health system and probably the declining growth probably fixed gross domestic product as well. And so there was a gross overhyping of what they were supposed to do. But they also set up an alphabet soup of agencies. They also started information provision, and they changed financial incentives on hospitals. What this government appears to be doing is shifting costs. It's using a narrow set of levers. So I'm suggesting that when we're trying to change the whole system, when we're trying to improve, to develop affordable and quality care, we look at the range of policy levers, don't just look at a few. And the policy levers I just talked about were top-down policy levers. We also should think about the bottom-up policy levers like consumer empowerment, consumer engagement, and consumer choice. The third suggestion I have, the third tip, is to remember that financial incentives on consumers may have perverse consequences and may reduce equity, and certainly reduce equity. And so, you've heard a lot about the $7 co-payment, for example. Just think about this. A visit to a doctor costs the Commonwealth Government about $100. By the time you have a $36 or so visit charge, maybe some pathology, maybe some x-rays and so on. A hospital admission costs $5,000. So if just 1 in every 50 people who would otherwise have gone to a GP and don't end up in hospital because their condition has worsened, there is no saving to the health system at all. So that's an example of perverse consequences. There's the other example of the equity issues with the co-payment. People in the lowest 10% of income in Australia spend about $10 per month. People in the highest spend about $30. But the percentage, people in the lowest quintile, lowest decile, lowest 10%, spend far more of their healthcare, and some of those people in the lowest decile spend a lot. That is, 10% of people in the lowest decile spend more than 20% of their household income on healthcare for those who spend it. So there's significant equity issues with the co-payment. Fourth tip is this: financial incentives on providers' work. We can dramatically improve the health system by improving the way we pay hospitals. There's a lot of waste in hospitals. We estimated at Grattan there's $1 billion to be saved through improving hospital efficiency. There's significant savings to be made in workforce redesign and so on. We also, the Labor government introduced a financial incentive on the Commonwealth that said you are going to share the costs of hospital growth, which meant there was an incentive on the Commonwealth to do things to stop hospital admissions. They're basically the ones who fund most of the primary care activity. The Commonwealth funds most of the primary care activity. And so the Commonwealth could have an incentive to actually expand primary care to stop people going to hospitals. That would then save the Commonwealth money as well, because it was sharing in the cost of growth. The current government, or the budget in 2014, has abolished that incentive, so there's now no incentive on the Commonwealth government to try and rein in the cost of the hospitals. The fifth tip is this: try to avoid anecdote-based policy. I know anecdotes sound good. I know they can help in selling a policy, but it's a good idea not to base your entire health policy on one story, especially if that story is made up. So, there is a whole lot of evidence, a whole lot of data in the health system that we should be using. And so we support evidence-based policy, not anecdote-based policy. The sixth tip is this: I think it is unethical to reduce quality or access to services when there is waste in the system. That is, the first choice in policy should not be to cut services. the first choice should be to do the hard yards and address the waste in the system. To give you one example, the government has estimated that the increase in the co-payment for pharmaceuticals will save about $450 million in 3 years' time per annum. Now, that savings estimate does not include any of the downstream costs that if people don't take the drugs that a doctor has prescribed, their condition might get worse, they might get sicker. And there's evidence to show, in Australian evidence to show, that that is actually what happens when you increase co-payments. But anyway, put that aside. We've done some analysis at Grattan which says this. Another thing that we have in Melbourne is a computer. And in Melbourne, we can access a thing called the internet. I know you don't have that mark in Canberra, there's no such thing as an internet. But one of the things we can do with access to the internet is to look at the prices that other countries pay for drugs. And so we looked at 20 drugs and looked at the prices they pay in England for those 20 drugs. And we compared them a month or so ago, the price paid in England a month or so ago, and the price paid in Australia to pharmaceutical manufacturers a month or so ago. So, if we paid the same in Australia as the English NHS pays, we would save $530 million a year, $580 million a year this year, or next year. So you'd save $130 million more, the taxpayer would save $130 million more by benchmarking our prices against England rather than a co-payment. Now, Grattan is a small research institute, a small think tank, total of 30 staff, the health team has 3 staff. Now, I know we have the advantage of the internet, and the Commonwealth Department of Health doesn't have the internet and so can't do this, but maybe they could actually get the internet connected and compare the prices they pay in England, New Zealand, Canada, and more than 20 drugs. Anyway, and not only would, if we paid less, consumers would also benefit because they would pay less as well because the price would come under the co-payment threshold. I've been heavily criticised by Guest Boom for saying this, pharmaceutical industry, which is a big shock. But anyway, they said, oh look, you compared the prices on the same day a couple of months ago. What if you compare the prices on another day in a couple of months' time? Because prices are going to drop on the 1st of October. And they said, that is going to destroy your whole argument. It does, sort of. Instead of, on average, paying 7 times as much as the English pay, we're going to pay 6 times as much as what the English pay. It's a big, big change. But anyway, so the first thing is reduce waste, and Adam, I think, is going to be talking about that as well. My final tip is this: get real. Be realistic about what can be achieved by when. If you're overwhelmed by this sustainability panic, you go for so-called quick fixes, which aren't fixes at all. You actually are distracted from addressing the systematic issues we have to address. Are we paying GPs the right way to look after people with chronic illness? We pay fee for service. Should we be changing that? Should we be doing things differently? We've got to plan for the long haul. We've got to do what I call the grit in the oyster. You put the little grit in the oyster and it irritates and irritates. Eventually a pearl comes. But the point is, it takes a while for that pearl to develop. It doesn't have to happen overnight. And the so-called quick fix won't work. So they're my 7 tips. Thank you very much.
Now we've got time for about 2 or 3 burning questions. We've got one right here. And one up the back.
Yeah. Thank you so much. That was truly wonderful. Can I take you home? I'm very keen to hear in just a bit more detail about your ideas about reducing waste. What are the things? What are the first things that you would target?
Well, so We've done some work at Grattan on this. We started, we've got a number of programs we're working on. The first one, we're working on waste access and prevention. In waste, we've done some work on public hospitals, $1 billion of savings. Everybody thinks we're too conservative in our estimate. We've done work on hospital workforce, $500 million to be saved there. We've done work on pharmaceuticals, somewhere between $500 million and or so to be saved there. So there are places where we can save money. We've also looked at places where there may not be money to save. End-of-life care being an example of that. Everybody says, oh, look, you know, we're spending way too much money on end-of-life. Well, we think maybe not, but there are some of the examples. It's addressing the inefficiencies in the provider system. As a general rule of thumb, I think, as I said, my third or fourth tip, incentives on providers work, incentives on consumers have all sorts of perverse effects.
Hi, so that was great. Just a quick comment, I guess, and I'm wondering whether you have any thoughts on it. In my experience, I do a lot of work with children and young people, particularly around chronic illness, and a lot of them are definitely, once they hit the workforce, in the lower end of the scale because of, you know, how they manage their diseases and whatever. They can't work, you know, normal hours and get stuck in casual and part-time work and that type of thing. On what you were saying about, you know, the lower income spending more than the higher incomes, do you think that comes from the fact that most of the people who do actually have these complex diseases and do require more complicated care are actually in the lower pay grades, or do you think it's just happens to be?
We haven't looked at that. What we did look at, the figures I quoted, we made 2 submissions to the Senate Committee on Community Affairs. One of them is a general inquiry on out-of-pockets and the other one is a specific inquiry on pharmaceutical benefit scheme. My colleague and co-author is presenting to the Senate today on the PBS inquiry. What we did look at was the amount of money that people spend out of pocket on healthcare by the number of types of professionals they visit, and basically it goes up substantially. The more professionals you visit, the more you spend out of pocket. The more different professionals, I mean doctors versus physios and so on, which is in a sense a surrogate for chronic conditions, because if you've got a chronic condition you almost certainly need more different sorts of conditions, but we didn't look at the combination of the two.
Yeah, hi, it's Martin Whiteley from the Health Consumers Council in WA. I read that paper you wrote, Bad Drug Deal, which I thought was an excellent paper about how we're getting ripped off by the pharmaceutical, for the prices we pay for pharmaceuticals via the PBS. It seems such an obvious case, and there's such a ready saving to be made, us mirroring the New Zealand model or the UK model. Why isn't it happening? Are they political barriers that are preventing the uptake of this idea? But it sort of came and went from the sort of the national debate. I'm just wondering why such an obvious idea hasn't been taken up.
There are a couple of points I'd make. First, every dollar of health spending is a dollar of income for someone. Either a dollar of professional payments or a dollar of salary or a dollar of supplier income. So when we're saying we want to take $1 billion out of the spending side, that means we're also saying we want to take $1 billion out of the income side. So it shouldn't surprise you to know that the people who's making a lot of profit on this, you have manufacturers who are prepared to supply a drug in Australia at this price and prepared to supply it in England, in Canada, in New Zealand at that price. There's a whole lot of profit sitting there. And there's a whole lot of profit that drifts down the supply chain. So obviously there are people arrayed against us. In response to this, Grattan has actually done the same thing 3 or 4 times, because we know that, say, the Pharmacy Guild is a very, very powerful lobby group, and they are lobbying all the time. They have full-time people who lobby all the time. At Grattan, we don't. We can't spend all of our time lobbying about pharmaceuticals. That's not what we do. So we've just tried to keep it on the agenda to increase the cost to government of not doing what we're saying. The second point third point is about diffuse and concentrated interests. The benefits of paying way too much fall on a few suppliers and pharmacists. The costs fall on all Australian taxpayers and all Australian consumers. And it's hard to get the consumers to be mobilised. I mean, Consumers Health Forum helped in this with their ticker thingo.
but it is hard to mobilise the diffuse voice of consumers to counteract the very concentrated voice of the people who benefit.
Excellent. We'll have more time for questions at the end of this panel discussion, so I might invite Adam up to talk. Can we thank Stephen?
Thank you very much. Now, I neither have the eminence nor the personality to roam the room, so I will. I'm going to anchor myself to this podium and speak from some slides. So, thanks for this opportunity. I'm pleased that I saw the little poll earlier that you've all filled out around what you would do as treasurer. I think I'm going to be well aligned with your position through some of the slides that I present here. So, I work primarily in the area of waste, or low-value healthcare, inappropriate healthcare. So when we talk about where there might be 7 ideas, 7 bangs for your buck, this is a graph that I have stolen from Don Berwick in the United States. And this graph covers most of the areas where we can eke some resources back and improve some quality of care through minimising waste. And you can see the categories that they fall into. So there's failures of care delivery and coordination, there's overtreatment, so unnecessary overtreatment, administrative complexity, pricing failures within the system, and we've just heard about that from pharmaceuticals and the like. And I'm going to give you some examples of those. So, inappropriate overtreatment. This is something that is really just coming to the fore really in the last few years, and it's happening because research is allowing us to measure how many patients we think are receiving a treatment or an intervention or a service when they were never actually a very good candidate for that service in the first place. And I'm representing that here in the boxes. So we've got the green box, which represents the patients who we think were very good candidates. There's the red box representing the patients who we thought were very poor candidates. And there's this grey area in between where we weren't sure. And there was a recent study in New York State looking at the cardiac diagnostic catheterisation database where they looked at 9,000 patient experiences in that database, and they declared that 25% of those were inappropriate. They should not have happened. Those patients were unnecessarily exposed to harm, and there was obviously a cost to the healthcare system that should have been used in other ways. Another example just came out of the American Academy of Orthopaedic Surgeons, where they looked at what would be the appropriate use for managing full thickness rotator cuff tears. They looked back at a cohort of patients, 53% they declared as being rarely appropriate in that group. And the list goes on. This study just came out only last month, the month before, looking at total knee arthroplasty. They came up with a 34% inappropriate rate. So this is really just starting to come on as a very strong wave. We know that there is inappropriate overuse of services, and trying to actually scale those back so we are treating the patient populations who we know are going to benefit from these procedures not only has the benefit of saving us money, but obviously it's going to improve the care of the population that is out there. An example that I wrote about in the Australian Financial Review in Australia had to do with vitamin D blood tests. So 10 years ago in Australia, we were doing about 90,000 vitamin D blood tests per annum at a cost of about $3 million per year. We're now doing almost 4.5 million of them per year at a cost of $145 million. Now, no one's disagreeing that vitamin D blood tests aren't a good thing for some patients, but nobody can justify this quantity of vitamin D blood tests. And we actually think that we should be able to get these down by 90%, and that would represent what would be an appropriate level of blood testing, which allows resources to be freed up and used in other areas. Put up your hand if you can think of a way of spending $100 million in the healthcare system tomorrow. Right, well, if we can get these numbers down, it's yours. You got it. And this is something that patients are recognising. So this is a survey done by the Commonwealth Fund in the US. It was an international survey where they asked, in the last 2 years, has a doctor recommended a treatment you thought had little or no benefit? And you can see in Australia, 17% of respondents said yes, they thought that was the case. The US was the highest at 20%, so was Germany, and the UK was the lowest at 10%. So this is something that is within the consciousness of the population out there. The second of my 7 is pricing failures, and specifically the pharmaceuticals. And I'm not going to dwell on that. Stephen has just told you about that and the work they've done at the Grattan Institute. Others like Philip Clark here at the University of Melbourne, Ruth Lopert have done work in this. So there is a chorus building around some easy gains to be made in pricing of pharmaceuticals. The second pricing failure, which is the third of my 7, is prostheses. It's exactly the same. It's an analogous example to the pharmaceuticals. But again, we know that in Australia we're paying much more than comparable countries like the UK and Canada. And in fact, Private Healthcare Australia has estimated that we're paying 5 times higher prices than the UK for our hips and our knees, the prosthesis that we're implanting, and that the government could be saving anywhere between $246 and $420 million per year if we could just bring those prices back in line with what's being paid for on the international market. The other thing that's happening is the pricing failures of medical services. It's probably not very well known to you, but we need to revisit the relative value of services and time that physicians spend when they treat their patients. The Medicare benefit schedule and the fees that go along with each of those services were actually based on what were the most commonly charged fees back in 1968, 69. And they've just been tinkered with and indexed in that time. So I think it's time for us to start asking questions. Are GPs being sufficiently remunerated to engage in shared decision making, which is actually something that we all think is a positive thing? We want GPs to be able to spend time with their patients, sit down with them, but are we paying them enough relative to how much we're paying some of the hyper specialists out there who are doing short procedures at fast rates? And this is a bit of a blast from the past. You might remember the cataract debacle that came out of Australia some years ago, where the Australian government decided they were going to reduce the fee for cataracts by 50%. Now, in fact, there was actually a very strong rationale for that move. It was because when the fee was set for cataract procedures, these procedures took much longer, they required more staff, so the fee could be justified, perhaps. But now, these procedures are done in rapid time, they are now done by lower levels of staff, and we can churn patients through much quicker. So was it fair that an ophthalmologist should earn $30,000 a day from doing 10 of these procedures compared to what a GP is being paid? So the rationale behind this modification in pricing was actually quite legitimate. How it was introduced to the Australian public was probably not so well done by the government at the time, but I think it's a conversation that should actually happen again. Now, this is a complex-looking chart. It's actually not very complex at all. This is from the United States, and it's suggesting here that the sickest 6% of the population account for 50% of healthcare expenditure in the US. In fact, the sickest 1% accounts for 22%. The next 5% account for the next 27 or so percent. So what this tells me is that there's not one healthcare system fit for everybody. There are different people with different needs within a healthcare system, and we need to make our healthcare system responsive to the needs of these different population groups. And that leads me on to this idea of we should be developing and trialling new payment models. Again, leading on from Stephen Duckett, who says we need to get our incentives aligned to improve quality and efficiency. We know that fee-for-service systems rewards quantity over quality. It also presents barriers for horizontal coordination of care. And in Australia, we have this debate where we think we need new models of care. You open the newspaper and you'll see lots of research being done about how we should have new models of care to treat different patients and coordinated care. And we're aiming for this safe, effective, appropriate, cost-effective healthcare and patient-centred outcomes. But what's being left out of this equation is in the middle, we have this completely fragmented payment model. And we're expecting the Australian population, the public and patients to navigate this mess. And now Australia has the second highest out-of-pocket cost for healthcare in the world, behind the United States. So just when every other country is doing the opposite and they're trying to reduce financial access barriers, Australia is moving in the opposite direction. We're increasing our financial access barriers. So my sixth idea is to turn this around. We need to flip the script. We need to think about what would be a safe, effective, appropriate, cost-effective healthcare, and we need to work backwards from there. We need to develop the optimal care models that will deliver that. And then we need to go back and think about what are some of these coordinated payment models where we break down these independent silos of payment that currently exist. Finally, my seventh idea for today is let's invest in taking the pulse of the healthcare system. We're spending $120 billion a year on healthcare in Australia. And in 2011, the National Health and Medical Research Council spent only 2.8% of its project grant funding on health services research for us to actually understand how healthy the healthcare system is. And we need to take this longer-term view in how we can improve the healthcare system rather than this rapid-fire, short political cycle points. So for anyone who's keeping tally there of the figures, the first three items alone promise to save us almost $2 billion a year. So to Stephen's point, this is not about trying to impose any kind of damage to patient care. It's actually doing the opposite. We're trying to improve patient care, and at the same time, we can deliver these savings. It's not an either or, it's both of those things. So it's a win-win for the system. And that's all I'm going to say. Thank you very much.
All right, 3 questions for Adam. First one here, second one there.
That's all right. On the issue of the inappropriate treatment, kind of the elephant in the room is the utility of care towards end of life, the whole issue of the 87-year-old coming in with a major stroke and then being kept alive in emergency, then sent to ICU for 10 days and eventually having the life support system turned off. Have you done any work on that aspect of inappropriate treatment?
You know, I haven't. And it is an important area, but actually I have kept that as a completely separate category in this whole debate about what is inappropriate or low value care, because I recognise actually that there are many more philosophical dimensions to end of life care. And, you know, we often hear this notion of rationing. What is rationing? Well, rationing has been defined as withholding a beneficial treatment for cost reasons. My approach to waste has been that we're not actually looking at beneficial treatments at all. We're looking at ineffective, low-value procedures, so it doesn't fit into the rationing debate in the slightest. But I think your point about end-of-life care is a very reasonable one, and I think it's one that Australia needs to have. It's not something that I've done a lot of work in, no.
And if you're in Melbourne tonight, the State Library, there's a presentation on this from Grattan at 6 o'clock tonight at the State Library.
I promise I was awake and I promise I was listening, but I might have missed it. Inappropriate care, that was defined how?
So inappropriate care is low-value care, so care that is not going to deliver any patient benefit. So the patient was not a candidate for a service. They were not going to derive any kind of benefit from that service by undergoing a procedure or a service.
And in that research, how was that decided post-treatment?
So that's a good question. So the reason this research is now coming to the fore is because clinical groups have sat down and they've actually defined what is an appropriate, they're called appropriateness criteria. So if you look at 100 patients and you look at the characteristics of those patients, it's defining what sorts of characteristics a group of patients have that will mean that they are a good candidate for a service versus a poor candidate for a service. And we know from research evidence that some patients who go through are poor candidates because they're just not going to benefit. They're going to gain no health benefit at all, and in fact are going to be harmed by procedures most often. So it's differentiating those two groups out.
And that can't be done beforehand?
It is starting to be done beforehand. Okay. So that's exactly where this research is going. We can look back at patients and see which ones were good or bad candidates. Mm-hmm. The challenge for us going forward is to be able to predict those patients going forward so they don't undergo the procedures in the first place. That is the holy grail of this work, yes.
Thanks so much.
Okay, one more question. Might go. Oh, is there something from this side of the room? Because this side of the room has been quiet. Diana? Sorry, there'll be time at the end.
I'm Diana from the Nepean Blue Mountains Medicare Local, but I just wanted to say that we need to be careful that consumers don't get a negative from some of this. I call the cataract conveyor belt of removing cataracts. And if you happen to have a chronic disease or a mix of chronic diseases as a consumer, you actually can't stop the conveyor belt to actually get the care you need.
Right.
So I think we've got a balance somewhere there that individual consumers can actually be empowered to go in and stop the conveyor belt.
Absolutely. Couldn't agree more.
Excellent. Can we thank Adam? And I'll invite Jennifer up.
Thanks, Adam and Stephen. And I'd like to also recognise the traditional owners of the land and reiterate Stephen's words about really being thoughtful and thinking about what they mean in a context of a debate about health policy. I'm taking as a theme today the 7 wonders of the ancient world. I think it's a good metaphor for what we're talking about today for a couple of reasons. Firstly, I think we've seen in the recent post-budget debate how important Medicare and our public health system is to our community. These are all icons, as it were, of ancient civilizations that represented something to them that was important. And I think to us and to many people in our community that Medicare and public health is also seen as a symbol of our society and reflects some of the values that we have. Also, as probably some of you will remember from your 5th grade projects, there's only one of these that's still standing. And I think that's also appropriate for us to remember that things that are important to us as a community, we can't be complacent about them. We need to continually value them, to improve them, to look after them, and not to assume that they're going to be there forever. If they're things that we value, we really need to fight to preserve them. So the first one I think we need to talk about is, as Stephen said, the myth that we have a health funding crisis. And as you can see up there, we've got 2 quotes from our Health Minister and our Treasurer, which, as Stephen pointed out, are sort of Henny Penny-esque comments running around the skies about to fall in. And as we know from Stephen and other health economists, that's not actually the case. As you probably know, we spend about the OECD average on health funding. Our projected demand is relatively predictable. This is from the National Commission of Audit, which shows a steady predicted demand up until about 2050, something that we can manage. Our change in health expenditure as a percentage of our GDP is tracking relatively evenly, which means that we're spending within our budget. So even though our healthcare costs are rising, our GDP has been rising as well. So our affordability is remaining relatively the same. And some work by Ian Macaulay of the University of Canberra shows that really on any realistic projections on our future GDP trends, we can continue to spend more on health and still be in material terms better off in 2050 than we are today. So we're far from a crisis situation. I mean, clearly that doesn't mean we shouldn't be talking about value, and regardless of whether we're spending 1% or 30% of our GDP on health, we want to make sure that every dollar we spend gives us good value. But it certainly doesn't mean we should feel forced into a crisis situation where we need to take short-term reactionary policy steps that are going to cause us more harm in the long term than good. So the second wonder of the world is the easy gains, the low-hanging fruit, and we've heard a couple of those from Stephen and from Adam. So, and I won't go through those in any huge amount of detail, but a couple that haven't been mentioned already is the private health insurance rebate, which is currently costing around $5.5 billion a year, without getting into a debate about whether the policy goals of that initiative are worthwhile or not. Even if you accept the aims of that program to help people access private health services, there's a lot of research and modelling that's been done by economists which shows that the mechanism of funneling that money through private health insurance is incredibly inefficient. So even if you preserve that funding for services, for consumer payments for services in the private sector, you could remove private health insurance from the equation and probably shave $2 or $3 billion off that. The other one that hasn't been mentioned is some work by Dr. Tony Webber, who's the ex-head of the Professional Services Review, who's also looked at MBS and PBS reforms and looked at saving approximately $2 to $3 billion a year just through changing the way that we fund Medicare and the PBS, some of which has already been talked about by Adam and Stephen, but his suggested changes are a bit broader than that. So compared with what's predicted to be raised by the co-payment, which current modelling from the government suggests that $700 million over 4 years. As we can see, we've got a lot of easy gains there. Oh, and just to reference Adam's, the $500 million is from something Adam wrote saying picking 26 low-value procedures. I think he predicted that would be just excellent. I got that right. So, as Stephen said, while we've got gains like that on the table, it's unethical and also incredibly inefficient to be chasing individual consumers for $7 here and there, creating barriers to access when there are some of these much bigger fish we could go after, just to confuse the metaphor. So thirdly, data. As both Adam and Stephen have raised, we're living in an era where we've got more data available than ever before in the health system, and we should be using that data much more than we are already to improve the way that our health system works. Here's some of the ideas in which we could do that. Obviously, I'm sure you've all heard of personal controlled electronic health records, and you know the gains that can be made through having an electronic record that's controlled by the consumer, and they can use to access different health services, to reduce repetition, to reduce adverse events and errors. I think what's really important when we look at how things like electronic health records can improve health system performance, we don't just look at the costs to, say, hospital budgets and the reduction in waste or in duplication. We also factor in consumer time and effort, and because that is a resource, and that's an important health system resource. So if it stops or reduces the time consumers have to spend giving information twice, taking extra records, filling out forms, then that is also a savings to our health system. I think Adam or Stephen talked about joint replacements. So there's a lot of data at the moment in the joint replacement registry that talks about the performance of different prostheses, and that at the moment is only available, only in a very diluted form available to consumers. As Stephen said, there's a lot of data that's locked up in government databases, which policymakers, which consumers and clinicians don't have access to. There's data that is available to doctors, but there's no compulsion on them to actually look at the data and use it. There are a lot of barriers to consumers accessing data that would help them make decisions about the best care for them. So the next one is primary care. As I'm sure everyone knows, primary care is the foundation of our health system. It's where most people receive their care. It's where many of the gains that can be made in improving access to health service and improving health status across the community. There's a lot of research internationally which demonstrates that by investing in primary care, by creating a very accessible and robust primary care sector, we can reduce healthcare costs elsewhere in the system. The system becomes overall more efficient. It's also very important for the overall equity of our system that we have a universally accessible and high quality primary care system. We can reduce hospital costs down the track, and we can increase consumer satisfaction overall with healthcare. And that's where we should be focusing, rather than creating barriers to accessing primary care. We should be focusing on reducing current barriers and making it more accessible. We've certainly, I think, come a long way with primary care reform through the cycle of divisions of general practice, Medicare locals, and now the new iteration. And we've certainly made a lot of gains in terms of how the primary care sector works to look at population health outcomes, to focus on prevention, to manage chronic disease. But it still seems often that we're really looking at our primary care system as a road that there's only one isolated health consumer with one simple problem going down, rather than looking at it as a system that really has to deal with people with chronic and complex problems and multiple issues. And I think just as we wouldn't look at a road and think, well, it's doing its job if on 2 a.m. on a Sunday morning you can drive down without any problems. We need to look at it at peak hour and look at if it deals with a traffic flow, between 8 and 9 and 4 and 6 on a weekday. We also need to look at the health system and see whether it's working for the people that use it most and use it for the most complex and most difficult problems. People with chronic diseases are the daily commuters of our health system. And if the health system doesn't work for them, then it's not working at all. So to improve primary care and to increase the flexibility of our health system, we really need to look at some of our work practices. Saying we want a mausoleum of archaic workforce practices. I think although in many ways we've fiddled with some aspects of our health system, we still have very rigid professional boundaries, and we've still inherited a division of professional responsibilities from a generation or two ago, or even further. We're very good at sort of tacking things on to, say, our traditional general practice models, so giving doctors a bit of funding here and there, or putting a person in a GP surgery, or paying for them to talk, on the phone for 10 minutes once a month to try and coordinate care. But we're not very good at breaking down some of those barriers that really look at, well, how, from the ground up, how do consumers want to be cared for? How do they want to access primary care? What would be the best way from a consumer perspective of having a chronic disease monitored and treated? And how then can we structure our workforce to meet those needs? And here are some alternative or ideas for some other health professionals, some of whom are playing an increased role in our health system, but still very much as add-on and still very much within the traditional sort of GP medical model. And just as a reflection, I think, healthcare is, although for all its sort of use of technology, in some ways health care and the health system is such a conservative part of our society, and in the last generation or so we've changed so much about how we access other services such as banking, entertainment, education, shopping, but still going to the doctor is pretty much the same as it was a generation ago. And I think there's a lot more we can do, and we can be a lot more creative about how we access that very important part of our life. But to do so, I think we need to storm the temple of the AMA and the Pharmacy Guild, because as I think pointed out by Stephen, there's a lot of barriers there to some of the changes that consumer groups and health system researchers and academics have identified as some of the problems, and as is the case, as Stephen identified with the savings in the pharmaceutical sector, the barriers to change are often those vested interests in the health system. So things like fee-for-service, which everybody knows does not work well in a number of different situations for people with chronic illnesses, for prevention, for people that are seeing multiple providers. It doesn't help cross professional boundaries. They're things that have been resisted repeatedly by the AMA, not necessarily obviously by individual doctors. There's many doctors out there who completely disagree with some of the political positions taken by the AMA and who do their best to work around a very inadequate system. But I think we really need to look at taking on some of these vested interests and saying, well, do we need to keep these rigid professional boundaries? Is it appropriate in this day and age that doctors maintain their role as a gatekeeper to Medicare? Are we happy that they can have secret negotiations with the government about consumer payments, about services that ultimately are paid for, whether through taxes or through out-of-pocket costs by consumers? Is it okay that doctors can have no geographical restriction on provider numbers, that they can access payment from taxpayers wherever they choose to work in the country, leaving a number of areas of the country significantly underserviced? Is it okay that you can have restrictions on pharmacies that are not based on consumer input but based on protecting a market share for pharmacists? Do we want to look at capping fees, as has been recently suggested, for some areas of medical specialty which are charging way above the Medicare schedule fee or even the AMA recommended fees? So I think as Stephen said, these people are, they do a good job for their sector, and good luck to them, but they are very serious and invest a lot of time and resources into their lobbying efforts, and it's not easy to change that without doing something similar. So, and just to conclude, I'd just like to remember the important role of consumers and consumer groups, and the important work that you are all doing to hopefully make our health system better for the future. And I think it's always important to remember, however good these ideas are, it's very easy to for people like us who work in a particular area to get a little bit obsessed with, say, co-payments or waste or a particular area of health savings that we work on. Not that I'm implying that Stephen or Adam are obsessed with their area, but just that it can be very easy to get a bit obsessed with coordinated care or whatever your particular bugbear is. And just it's very important to remember that these things are, all good as far as they go, but they're only good insofar as they meet consumers' interests. So as much as we want to talk about improving primary care or coordinated care or reducing waste, we need to keep asking ourselves, why and to what extent is that going to meet the interests of consumers? There is no point cutting out a low-value service if it's not low value to consumers. There's no point in coordinating care if that's not a high priority for that group of consumers that you're coordinating the care for. So I'd just like to conclude with saying that, in all our deliberations about the co-payment, about what we should be doing instead of it, let's try and keep front and centre the interests of consumers and make sure that whatever recommendations and conclusions that we come up to, that they're ones that are actually going to advance consumers' interests in the long term. Thank you.
Three questions for Jennifer.
I'd just like to talk a little bit about the fact that what Adam was saying and what Jennifer was saying about the co-payment, the fact that bulk billing practices, maybe it's the doctor that's actually taking the hit rather than the service being of lesser value. There was a little story in Perth. There was a plastic surgeon who decided he didn't want to do breast augmentation anymore, so he doubled his fee, and he had a line out the door because they thought he must be so good at this that I'm going to actually go to this guy. And what he was trying to do was say, well, look, if I have a ridiculously high fee, you'll stop coming to me. I think that in lots of cases the consumer doesn't perhaps understand the value for the service and where the actual costing comes from. Is there some work we can do with actually informing people of that?
Stephen? Adam?
It's a very good point, and it goes to the fact of why the health market is a failed market, because of those issues. So the work I think that's probably coming up that's most related to that has to do with the Choosing Wisely campaign. So watch your TV screens. Pretty soon you'll hear about Choosing Wisely. If you're not sure of what that is, it's a program out of the United States where specialty groups were asked to list the top 5 services that they thought were the lowest value for their patients. And then the idea was then to spark a conversation with patients to talk about what the value proposition was. And that's now come to Australia. So NPS Medicine Wise has commenced the Choosing Wisely campaign. And it will hopefully have a very strong consumer element to it to have those conversations. Yes.
I think that question also goes to Stephen's point about the perverse outcomes you get when you actually try to introduce consumer price signals, that they don't always result in the outcome you're looking for.
Jennifer, I was delighted with your presentation because you actually brought the consumer into the equation. And I had 2 principal points that I think should kind of embrace all the presentations today. And one of them is about the consumer has to be in partnership. However we define it, however we do it, it's critical that consumers take control of their health and take control of the conversation with how they work within the health system. So they have to be well informed and they have to be able to navigate the system system. So the less complexity, the better, because then not only does it improve efficiencies, but actually it improves the pathway for the patient and the consumer. The other point is that I think at the end of the day, we should not forget that health has a component of what I consider to be ethics and compassion that has to be part of that conversation. So I would not be very comfortable hearing things such as someone who's 95 should not be given and there should be withdrawal of care, or someone who has a severe disability should have withdrawal of care because we're looking at rationalising resources. We need to be compassionate, we need to be considered, and we need to ask those individuals and their families what it is they prefer. E.g., if I'm 60 and I want to end my life because it's too intolerable as a result of a range of things and I'm terminal anyway and withdraw care, I should have that opportunity and that option. But it should be done in an ethical and compassionate way.
Yep, I absolutely agree.
Jennifer, I'm actually picking on you, and I would like to address it to everybody. Nobody is talking about allied health. And, you know, so many people, particularly the ones we keep talking about, people with chronic care needs, need lots of help from allied health people and from the growth of rehabilitation centres, all of which helps keep people out of hospital or from going back to hospital, but it isn't being mentioned in terms of its cost and its value. Could you say something about that for me, please? Because it's been left out of the Medicare locals. These people were so thrilled to be recognised at last, and now they've been wiped without a mention.
Yeah, I think it's absolutely important, and I think if any sort of positives come out of the current debate about the co-payment for GP primary care services, it will be to broaden out the debate to look at out-of-pocket costs for all healthcare, and allied health is certainly one that really falls through the cracks, that people, you know, with private health insurance face high co-payments and caps on the number of services that they can access. People without private health insurance often face the entire cost of the service. Even if they're under a chronic disease plan, there are limitations on the number of services. And I think the co-payments can be staggering. I was talking to a mental health consumer in rural Tasmania, and they have to pay $600 for a psychologist to visit their town for a single visit. It's 2 hours travelling time each way plus $200, so it's $200 for each trip there and back, and $200 for the actual consultation. Because of other physical health problems, they can't travel into the capital city, and they have to pay that out of pocket. I mean, that's just staggering. So I think it's absolutely a very under-researched policy area. I think it's something that neither level of government has wanted to take on. They're basically too scared of it. Governments, Liberal governments have tended just to put it in the sort of too hard basket to look at private health insurance as a solution and say, well, we're funding that, and that's a policy solution, when it, you know, in reality it really meets the needs of only very few consumers in terms of accessing allied health. And Labor governments have tended to look, as you said, to Medicare locals and how they can support that infrastructure at the local level, and you know that has not been allowed to evolve to the point where it's actually meeting a lot of consumers' needs either. So it is a big vacuum there, and it's certainly an area that I think needs a lot of attention. And hopefully, out of the current debate, as I said, there will be some at least recognition of the need to do more in that area to address access and out-of-pocket costs. Sure.
All right, can we thank Jennifer? And can I now ask Andrew to come to the podium?
As Stephen said, my problem is coming last of it and whether I've got anything new to say. It probably worth identifying that there are a couple of differences I'd have with my colleagues on the table. Let me start off with one, because I'm not in fact opposed in principle to a GP co-payment. A well-designed co-payment can constrain excess demand without upsetting equity. This was demonstrated back in the early 1990s when the then Labor government introduced a co-payment for pensioners in the PBS and other concessional groups. But what they did was that they reimbursed Social Security recipients fully for the co-payments that were in place, but they still got a big saving to the budget because there was reduced demand as the doctors reconsidered whether a prescription was sufficiently valuable for their patients to contribute to their costs. So you actually got a saving to the budget, money was given back to the Social Security recipients, but you had a charge. But this latest co-payment proposal hasn't got anything going for it because not even the budget gains, at least not for many years. Nothing is redirected to patients or to primary health care, and there's been no attempt to look at a more coherent system of co-payments across the health arrangements. And there's been no discussion in that of genuine safety nets across the aggregate of the health system. So it leads me to my first idea to put to this government would be, you're not going to get your GP co-payment, why don't you get the Productivity Commission to do a paper on the future role of co-payments and safety nets to contain excess demand, but also to ensure that it doesn't present an obstacle to effective services, that in fact it could be designed to improve the effectiveness of Medicare as an insurance product by setting limits on co-payments. Why don't we have deals with doctors which say that if we're paying you this money, then we expect your co-payments to be no more than X or Y across the country? A system that has a clear picture of what the aggregate out-of-pocket expenses should be. Indeed, it'd be nice if such a system also applied to those with private health insurance, that they had effective insurance. You may remember we did some work some years ago on the idea of no co-payment or known co-payment, but we've never really followed that through about what PHI should provide as clear aggregate safety nets in that field. So, given that the claim purpose, however, of the $7 is to address the so-called sustainability of the health system, my other ideas are mostly to do with improving cost effectiveness and total cost controls. So I wouldn't throw out the co-payment idea as such, but I think they go back to TORS and say, what's it about? What might we want to look at for the system as a whole? But as I say, my other ideas are more about cost effectiveness and total cost controls. The second one picks up something the others have said a little bit about. The federal government should take its responsibility as the main national insurer more seriously. It should start analysing risks and providing support for best management of those risks. Rather than focus solely on each health program, it should be linking the data, identifying trends and patterns of risk, so as to inform planners and managers of services about the most cost-effective way to identify and care for high-risk groups. Such analysis should provide guidance at national, state and regional levels. The problem is we no longer have a thing called a Health Insurance Commission, and even the cut-down version of Medicare Australia that merely administers payments looks as if it's likely to be privatised. So I'm not too sure at the Commonwealth level who could take on this task, but it must lead to public reports, involve medical and public health experts as well as statisticians and economists, and it must link to consumer organisations representing the high-risk groups identified. So a proper insurance risk analysis work is a responsibility, I believe, of the Commonwealth Government. My third idea is that we should start taking some steps to improve allocational efficiency, in particular by moving towards global health budgets for different population groups. Now, we can't do that all in one go, but I suggested some years ago that the AIHW could identify total health spending by regional populations that might help the development of what I called notional regional health budgets, identifying from that what discretionary monies should be allocated to address key risks and what current allocations should be kept under close review, whether through public hospitals or MBS or PBS or whatever. This would help guide the regional health planners, whoever these may be in the future, and it might also lead in time to possible carve-outs for high-risk groups, drawing on the lessons from the 1990s coordinated care trials. So you can think of carve-outs for particular chronic illness groups that might be done more than within each region. Fourth idea is that we could also widen the private health insurance fund's responsibilities for its members in the same sort of direction of more global budgets. But I wouldn't start with primary health care, which is what the government's position is, but I would start with public hospital care. If funds were required to meet all the hospital costs of their members, their interest in the health of their members would greatly increase. They might also then come under pressure from members to provide more comprehensive insurance cover, limiting out-of-pocket expenses. The windfall gains and losses involved would also require the Commonwealth to find a more coherent approach to its support for private health insurance, one which might encourage competition and efficiency rather than at the moment the system which simply forces us to be members if we're on higher incomes without ever valuing what it is we're getting or putting any pressure on the funds about their performance. I'd complement these measures at improving allocation efficiency with continued effort to improve technical efficiency within our different types of services. I won't go through the same list, but this idea, my fifth idea, is really the same ones that the others have put up. Stephen Duckett's one about more use of generics and better pricing of pharmaceuticals. I should mention that the idea of private health insurance having to take responsibility for members' public hospital costs would have an impact on hospitals, both public and private, leading at long last to an even playing field of competition between public and private hospitals, both for public patient services and for private patient services. And within that idea, also thinking about changes to the MBS to move further away from just reimbursing patients to purchasing services on their behalf, shifting further from pure fee-for-service to blended payments and indeed to contracts, at least with corporates, that will reward doctors for preventive health and other cost-effective measures for high-risk groups. The sixth idea is adding to this. It's no secret that I've always believed that the Commonwealth should be the national insurer, accepting full financial responsibility for the publicly funded health system, and that the states and the private sector, both for profit and not for profit, should be responsible for service provision. But I had in mind in the past that the Commonwealth should be the purchaser of those services, and I'm not so sure that that's right anymore. But certainly, pending any increase in Commonwealth financial responsibility, which now seems a very long way off, I much prefer Stephen's push for the Commonwealth to share both the pains and the gains involving managing the system's risks, rather than pretending it can shift all the risk back to the state governments. And consistent with this, I suggest some further experimentation of regional health planning and commissioning that recognises the professional values and independence of providers while using competition, benchmarking and risk management to maximise cost effectiveness and ensure overall cost control. This doesn't need to involve carefully constructed experiments in every case, but it could allow each state and territory to negotiate an arrangement with the Commonwealth that meets some agreed general principles and involves ongoing independent monitoring and evaluation focused upon some agreed outcome indicators. Perhaps a small state like Tasmania could even offer the opportunity to trial an approach involving the Commonwealth taking full financial responsibility in exchange for some GST revenue and having a genuine single government purchaser managing a global budget. Bearing in mind Tasmania's small population size, the risk to the Commonwealth in fact would be very small, and we could have a proper experiment to see whether a single funder, single purchaser process could actually work. Seventh idea, if the Commonwealth were to take full financial responsibility, it could of course consider in time the idea of managed competition. But I'm not going to devote my last idea to this will of the wisp. Instead, I'd like to put on the table another element of the Netherlands' health reforms of recent years. And this is to establish a loop in the budget process whereby if health costs do increase faster than revenues under existing settings, identifiable health insurance premiums must be increased. So, taking this idea, you would talk about, let's look more at hypothecated taxes like the Medicare levy, and let's test whether the public accepts the need to increase revenues when costs increase faster than GDP, or whether the public expects tougher action to hold down those costs. So hypothecated taxes might actually give us a loop and think about what does the public really want? Does it really want to spend more, or does it really say, no, we've got to cut things out? So they're my 7 ideas, but you can see some differences with my colleagues here. I do see there can be a role for co-payments, but the current co-payment system is a right mess. It's not just the $7. PBS ones at the moment are crazily high, and indeed, at the moment, I think it's 90%, Stephen, of the costs of the PBS are for concessional people. So the rest of us are only getting 10% of that cost. So it's a very high part is being user pays. Is that really what we expected the system to look like, and with other parts being totally free? Or is there a more balanced approach that we ought to be looking at to get that right? Secondly, I'm not as opposed to private health insurance as Jen is. Indeed, I think abolishing the private the private health insurance rebate would be just as much a knee-jerk reaction as the government's measures like the GP co-payment. I recall very much the Labor's means testing of the PHI rebate, which, if anybody looked at it carefully, was a total sleight of hand. Because on the one hand, the means tested the private health insurance rebate, and with the other hand, we increased the Medicare levy surcharge exemption arrangement, which in fact was a much cruder instrument, forcing many more people to take up private health insurance without having any idea why they're doing it other than for tax avoidance purposes. So we actually had a sleight of hand and not sensibly thinking about where should we be going about the role of private health insurance in our system. I'd also be a little bit beware of sounding as if we're doctor bashing. I think it's very important that we be very careful that if we're promoting multidisciplinary approaches, that requires an appreciation and respect of each of the profession's roles and culture in that multidisciplinary approach. We need to be careful about that. And finally, Stephen, I do actually object to Canberra bashing. Our problem is not the people who live in Canberra, it's the people who keep on coming into Parliament and telling everybody else what to do. So I think just be a little bit careful with the Canberra bashing.
Here. All right, 3 questions for Andrew, and then I'm going to ask for 7 questions on 7 ideas for $7. So, Jan.
All the issues you've raised are important issues for us as consumers to consider. Yesterday we had a very good session on the principles of consumer-centred care, and what they do, those principles, they offer us a framework for evaluating health policy. Now, the consumer organisations in Australia are under-supported, underfunded, undervalued. We work very hard with very limited resources. I'm very concerned about the direction health policy is taking in Australia. Not in the $7 co-payment is a significant redirection, and all the co-payments that Andrew mentioned are significant to consumers. The equity issues that Stephen's talked about are huge issues for us still. So what I want to ask all panellists is, given our limited resources and the fact that we all work extremely hard, we all sit on many bodies where we put in many hours and hours of work, very, as I said, undervalued. Which of your issues, is it the waste issues, the equity issues, the fragmented funding issues? Which are your issues do you think could make a significant difference to the way our health system is functioning for consumers?
My view is that there is no quick fix, no single answer. What I said was we've got to do the hard yards. There are changes, there's changes to the way we pay for hospitals, changes to the way we pay for pharmaceuticals, and so on. There's nothing... the health system is too complex that there's a single answer that will fix everything for either taxpayers or consumers or both.
I mean, I would agree. I think a lot of what I put up there were technocratic processes to try and move towards a goal, but the goal would be to getting back towards equitable access, and I think that requires some sort of progressive rather than regressive way of thinking about how we fund healthcare in this country, which has taken a big shift in the last little while.
I think in the current political climate, talking about reducing waste is probably going to get you into more, ministers' doors than equity. But I wouldn't suggest you stop talking about equity. I would also say, just in terms of, consumer resources, absolutely recognise all the hard work that consumers and consumer organisations do. But I would say that the current media environment and the growth of social media does offer a lot more opportunities for individual consumers and for interest groups and activists to engage in having their voices heard and engage in the policy debate and be heard by politicians and policymakers. So I think we are in an era where hopefully you know more people can work less hard and make a difference rather than relying on the few people who have to devote their lives to it.
I very much agree with Stephen that we need to think about the long haul, and it's a very complicated system, and you've got to think about how you move towards a better system over time. But yes, the government is looking for some immediate savings, and I think a few of the suggestions that have been put forward by the group here are ones which could be immediate savings. One of the things that's surprising me in terms of the government's politics on this is that I recall Michael Waldridge saying very firmly that he was not interested in any suggestion from the department for a measure that would only deliver efficiency gains. He said, look, that's going to get you nowhere in politics. You've got to say what it actually does in terms of improved health outcomes. So if we were talking about, if we'd simply talked about blended payments and fee-for-service, things would glaze, the eyes would glaze over. But if you said, why don't we have a reward for doctors to ensure that they've got a high proportion of their kids covered by immunisation? That reward was actually a capitation payment, it's a blended payment. But you didn't call it that, simply said we're going to reward doctors for a better way of looking at immunisation. And we got big results, good results, a lot of political support. I'm just surprised that, say, the primary healthcare, they're not saying, if we're going to put a charge on it, let's talk not about sustainability, but can we put some of that money into a better primary healthcare system? So I'm just surprised by the politics at the moment of this government. I would have thought they'd be cleverer and talk about a mixture of savings, but also what's been done to improve the actual quality of the services in the system.
Thank you. It's a great discussion. And Andrew, I think everybody's surprised about the politics of this current government. Michael Cousins, I'm from South Australia. One of the things I think I've noticed before the federal government, the federal budget and then our state budget, is that the health consumers I work with in the Health Consumers Alliance are very acquiescent to the dominant political thinking and paradigm. So we in South Australia, we've come from a forward estimates of $1 billion cut to our health expenditure that started two years ago. We apparently had the best health system in Australia, according to the then health minister, but we had to cut $1 billion out of it because they couldn't afford it anymore. And the health consumers that we work with, said, we know we can't have the best health system in the world. They agreed with the cuts, largely. They acquiesced. And I think the economic literacy of Australians is pretty poor. I'm wondering if the panel's got any comments about how to raise the understanding of Australians, the consumers and the community, about these rather complex and difficult to grasp concepts. Any good ideas up there? Because I'm sure you've got plenty.
Well, it's all relative, isn't it? When you think about how literate communities are, I would actually argue that globally Australians are very literate, given that we've been thinking about value in pharmaceuticals for 30 years. We were a world leader in that, whereas countries like the US are struggling to get their head around the notion of value in the first place. So we have to give ourselves some credit on that front. I have been involved in some research. It's called the Astute Health Study, and you can find it easily enough if you Google it, where we actually sat down with groups of consumers, also the general community and clinical groups and policymakers to actually discuss the notion of value and effectiveness and ineffectiveness. And we were actually incredibly, heartened to see the level of awareness and the level of engagement the community and patient members had with this notion of value. How we scale that up to a national level is, I think, a challenge, but we know that that the seeds are there for something that could be quite fruitful. So, yeah.
I'm not sure I've got an answer, but what I can say is what we do at Grattan is we try and make sure that the work we do is written in a way which is accessible for consumers so that they can read what we say. whenever we do a report, we also do a piece in the conversation, which is widely accessible again in trying to make it consumer friendly, and also pieces in the print media. Philip Clark has done the same sort of thing in his work on pharmaceuticals. I think Adam has as well. So we are so that's what we try and do. The academics are increasingly being rewarded for the impact of their work, not just getting something published in so-called special journals, but trying to actually get it out to consumers. So there are work that we can do in helping inform, but that's obviously not enough.
I'd like to know what everybody is thinking about as far as equity is concerned. Rural Australia has never seen equity. I can remember in 1996, a conference in Brisbane, where Stephen Duckett got up and said rural people and rural medicine would have to be much less in the 20 years' time if at all it was needed. I went with you, Andrew Podger, to the 1999 Rural Summit and was on the health, same as you. All I can see, as far as equity and access is concerned, for rural people, has gone from 0 to -000, because we are not getting equity. What Jennifer said about the cost just for one person of $600 to visit, let me tell you, it's happening all over the place. I was in Alice Springs recently, same as CHF, and the cost is astronomical. I myself have been out of pocket and have had to go to my house to get some money. I've had to have 10, 14 operations in the last 2.5 years, and I live in a rural area, and every one had to be done in Canberra or Sydney. So let's have some equity.
Perhaps I didn't make myself quite clear enough on the issue of a study of co-payments. What I was trying to propose was that rather than just simply saying there should be a mandatory $7 co-payment for going to a GP, let's look at a study which says what should the maximum co-payment be from wherever you are? What should the safety net be wherever you are? These things seem to me to be very important. At the moment, we don't take into account the fact that rural people generally don't get bulk billed at all, and basically because there's not enough doctors out there competing. But that's an issue for the Commonwealth to say, if we are purchasing services on behalf of rural people, what insurance product should they get? And that seems to me part of the equation of looking more carefully at co-payments is indeed equity. It's not about efficiency alone, it has actually got a very big equity element if we look at the co-payments properly.
I'm not sure what I said back in 1996, but what you said sounded consistent with my view that I foreshadowed a decline in access to healthcare in rural and remote Australia. In fact, what we did see was a significant increase in the number of GPs working in a regional centres, the major Indigos and Bathursts and so on of the world, and also, but the relativities versus metropolitan areas are still poor. We've got parts of Australia, quite large parts of Australia, Medicare local areas, where they have half the number of GPs as they do in the eastern suburbs of Sydney. The issue then is, what is our strategy to address that? And one strategy is to just pump more and more doctors out of universities, which is the one the current government, the previous Liberal government followed, which basically hopes that those GPs will eventually trickle down to rural and remote Australia, and that strategy clearly is not working. So then you have to say, well, what are the alternative strategies we put in place? And Grattan has done a report on that, which said for a moderate expansion of money, we could actually significantly improve access to primary care in rural and remote Australia. The other issue is the one that Andrew raised, which is the co-payments issue, which is significantly higher in rural and remote Australia than in metropolitan areas. And again, we need to be looking at equity issues to address that.
Hi, my name's Catherine Wright. I'm the National Policy Manager at Nacho. Has the panel got any ideas in terms of the $7 co-payment? And has there been any research done or impact studies about how this would affect the Aboriginal community control sector, given that it's already difficult to recruit GPs into that sector, and given that the government is trying to implement a low incentive gap, and that's on the basis that they charge patients $7, that's probably not going to be likely in our sector. So really organisations will absorb those costs, resulting in a reduction in their primary health care funding.
So I've seen a number of comments on the impact of the co-payment on Aboriginal controlled community health organisations. It is difficult. We were approached at Grattan to do some work on this, but the data are just not... We're asked to look at the impact on Aboriginal people, but the data are just not there. The data we used for our work on co-payments was a sample survey, and so it has I think there was about 5,000 people answering the question, maybe a bit more, about 8,000 people answering the question. And we just didn't have enough Aboriginal people in that survey to do any impact on Aboriginal people. So we haven't done anything, and I haven't seen any work specifically looking at that issue.
I don't know either, but what I would say is that for a government looking at the discrepancy in health between the Aboriginal and non-Aboriginal community, for a government to propose in a budget to introduce a co-payment without itself having done that work and being able to say what they're going to put in place to prevent this creating further barriers to access from Aboriginal people is really appalling.
It's Christine from the Chronic Illness Alliance. I think that issue that was brought up before about access and equity is a really important issue that we should be addressing. And it seems to me that the lack of it is partly due to it's a function of the way health is financed at the moment. And we had a reform agenda under the Rudd-Gillard government, which I found immensely disappointing. It didn't seem to be reform at all. And Stephen suggested in his speech that we should actually consider some real reform. And I'd like to see that the thinking about that actually starts. And I tend to think that it should be thinking and planning that is done using think tanks and consumers, and consumer experience in particular, and the less it includes politicians, the better.
I'm not sure you'll get any disagreement from the panel, but...
So I was a member of the Reform Commission, and I think our report was quite good. There were parts of it which were quite bad, but we tried to take a holistic approach. We made recommendations about intervention in early childhood to actually put people on a good footing and so on. Basically, the whole report was hijacked by one or two simple answers to fix all the problems. One is activity-based funding for hospitals and the other one medical locals, and all of the other nuanced stuff that we recommended was consigned into the wastebasket. So I still think it's a good report, but the implementation was flawed. Not, of course, anything to do with people in Canberra, Andrew. They are perfect as well.
How would you actually change, say, the funding of primary
it's a really, 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 really good question, because the evidence about what we ought to do is very, very weak. You know, that in theory we should say we should have a capitation payment that covers a person with chronic illness for a whole year and so on. And the theoretical arguments are very, very strong for that. But the actual evidence in Australia is very, very weak. And so I support sort of experimentation with this to see what works and what doesn't. And if you're going to have experimentation, it requires the politicians to say, we don't have all the answers and we want to try out doing things better. And that requires the public to accept fallible politicians. And it's very, very hard these days for politicians to recognise or to admit that they don't have all the answers, and there are issues that need to be explored.
Just, if I may, a couple of points. First of all, I think there were a lot of very positive things in the review that Stephen was involved with Christine Bennett. I think there were a lot of useful things, and a lot of it, unfortunately, wasn't followed through. I was a bit disappointed that they rejected their original option B arrangement, and I think it had a more practical approach to where we might be going on regional health arrangements than what we ended up with. But that said, I wouldn't just denigrate the politicians. In the end, we're all looking for political leaders who will run with things, and without that you won't get anywhere. And I've seen very good Commonwealth health ministers on both sides of politics, and I've seen very good state health ministers on both sides of politics. It is unfortunate at the moment we don't seem to have a dialogue around what are we trying to get out of the health system. All we've got is a dialogue around sustainability, which is just so narrow. And it seems to me that what we're looking for is from both sides of politics. So let's go back to TORS. What are we trying to achieve here?
And I just want to add, I just spent 3 years in the United States, and we just wrote a piece in the Medical Journal of Australia saying what can we learn from the United States. There's an awful lot we should not do from the United States, but there are some things we can learn. And one thing that the Obama administration has done, which has completely flown under the political radar, is they've set up what's called an innovation centre. It's well funded, and they're trialling different payment and provider packages throughout the country, some small scale, some larger scale, and they're trialling them for effectiveness. And they're setting stretch targets to 2017 and even 2022. So they're taking away the political cycle, and they're saying, let's learn from these and see where they work, where they don't work. And I think that's something that, as Stephen says, we could be doing in Australia if we take away the political element to it. Absolutely.
All right, our last question up the back. I'm sorry, but we're already 10 minutes into morning tea, so I'm keen that we get the last question in, and then you can talk to the panel during morning tea time.
Thank you. 16 years ago, I was a student teacher in the New South Wales Education Department. I was paid $30 a month allowance, and the quid pro quo was that I taught for 3 years wherever the Education Department placed me. Can that work for GP, for medicine graduates from universities today?
There has been schemes. The Rural Bonded Scholarship Scheme is the best example of that. I think the last report I saw of that was that there was a very high proportion of people who paid out their bond at the end of their study, so they actually didn't end up going and working in rural remote areas. But obviously, it is something that can be tried.
Yeah, and look, Australia is generally open-minded about this notion of paying for equity, and as Jennifer said in her talk, whether or not we should be having this conversation around a requirement being placed on the medical community, I think is something that is worthy of a conversation. Absolutely.
Excellent. Can I ask you to thank Stephen, Adam, Jennifer and Andrew?